such an opportunity to present in this conference. My topic for today is experiences with mucormycosis during COVID time. The scheme of my presentation is introduction, general description, representative cases, including DNA, CT, microscopy, then management, complications, discussion, and conclusion. Coming to the introduction, mucormycosis is an invasive fungal infection. It is very rare. There's a sudden surge in the number of cases during COVID season. The most common form being rhino-orbitocerebral. 10 histologically proven cases of mucormycosis which presented at our hospital are being discussed. Description. Of the 10 cases, the mean age of presentation was 57.3 years. 5 males and 5 females. 8 patients were COVID and 2 non-COVID. 9 of the 10 cases were diabetic. Now let's discuss few representative cases. First case was a 56-year-old lady. She was post-COVID, diabetic, hypothyroid, and she had underwent nephrectomy a few years back. She presented with right-sided facial pain, headache since 2 weeks post-COVID. On anterior rhinoscopy, it appeared normal, and nasal endoscopy showed edematous nasal mucosa. There was no crusting, but purulent discharge was present in the right nasal cavity. CT-PNS showed right maxillary, ethmoid, frontal, sphenoid sinusitis with obliteration of the right osteomeatal complex, as you can see in the picture. MRI brain showed enhancing irregular thickening, soft tissue, and retained secretions in the right maxillary sinus, extending to the right nasal cavity, ethmoids with subtle erosion of the right maxillary sinus and extension to pterygopalatine fossa and orbital apex. Histopathology came as tissue lined by respiratory epithelium. Underlying stroma edematous with inflammatory cells and cellular debris in the midst of inflammatory cells. Entangled broad aseptate hyphae with acute and right angle branching. Necrotic bone seen in the periphery. Inflammatory nasal polyp with fungal hyphae consistent with mucormycosis. The treatment given was endoscopic medial maxillectomy and frequent suction clearance with local application of amphotericin B. Liposomal amphotericin B was given intravenously to a total dose of 5 grams. Repeat DNA biopsy showed healthy nasal mucosa with no evidence of fungal elements. Patient became symptomatically better, her vitals stable, and vision was normal. And on follow-up, she is asymptomatic and DNA is normal. Coming to the second case, a 51-year-old diabetic lady presented with complaints of nasal discharge, nasal blockade, and headache. There was no history of COVID, and nasal endoscopy showed bilateral nasal polyposis. CT-PNS showed hyperdense material in bilateral maxillary sinuses. Overlying sinus walls appeared thickened with sclerotic changes, and there were features of pansinusitis. Is the CT picture? She underwent endoscopic sinus surgery, and histopathology was suggestive of mucormycosis. She was started on liposomal amphotericin B, but she developed acute kidney injury and electrolyte imbalance. Hence, amphotericin was stopped. Her post-operative nasal endoscopy was normal. She was changed to oral posaconazole. On 4 months follow-up, she is asymptomatic and DNA normal. Case 3. 56-year-old male patient, diabetic, hypertensive. Post-COVID, 2 weeks after turning negative, presented with nasal congestion and headache. CT-PNS showed mucosal thickening in bilateral maxillary sinus, bilateral anterior ethmoid air cells, frontal sinus, and left sphenoid. DNA showed black crusts in both nasal cavities, as seen in the picture. Her fungal stain from the nasal mucosa showed both aseptate and septate fungal hyphae. Fungal culture and histopathology was suggestive of mixed infection of Aspergillus and mucor. He underwent complete surgical debridement of the involved area. He was started on liposomal amphotericin B injection along with antibiotics. Frequent endoscopy post-op and local application of antifungals done. And this is the picture after the surgical debridement. He developed acute kidney injury after using amphotericin, and hence it was withheld for a few days and restarted when his renal parameters became normal. Patient became symptomatically better and DNA normal. But he developed a sudden cardiac arrest and succumbed to death. It was very unfortunate. The most probable cause was acute myocardial infarction due to hypercoagulable state associated with COVID infection. Now coming to the case 4, a 71-year-old lady, post-COVID, diabetic and hypertensive, presented with a history of headache, multiple episodes of focal seizures and weakness. DNA showed crusts in both nasal cavities. Fungal staining showed aseptate hyphae. CT brain with PNS was done, which showed an acute infarct in left corona radiata and temporal lobe. Bilateral maxillary, ethmoid, and sphenoid inflammatory mucosal thickening. MRI brain showed multiple acute infarcts in left temporoparietal region. There was optic nerve hyperintensity on left side. And MRA showed left internal carotid artery involvement. Here we can see an acute infarct. She underwent transnasal decompression and was started on liposomal amphotericin B. She developed a cerebrovascular accident resulting in hemiparesis and later succumbed to death. Now coming to the management in general. Complete surgical debridement of the necrotic tissue and disease clearance was done in all cases. Injection liposomal amphotericin B as slow IV infusion diluted in 5% dextrose at a dose of 5 mg per kg per day. Adequate hydration maintained. Daily renal parameters and serum electrolytes checked. Local application of amphotericin B postoperatively and oral posaconazole given after the amphotericin course. The complications included hypokalemia, acute renal dysfunction, cerebrovascular accidents, loss of vision, cardiac arrest, and death. Coming to the discussion part. Mucormycosis is an angio-invasive disease caused by the fungi of the order Mucorales like Rhizopus, Mucor, Rhizomucor, Cunninghamella, and Absidia. The common clinical forms of mucormycosis are rhino orbitocerebral, which is the most common form constituting 44 to 49%, then cutaneous, pulmonary, disseminated, and gastrointestinal. The clinical features include one-sided facial swelling, headache, fever, black lesions inside the nasal cavity or crust. Features a cerebral infarction in cases of cavernous sinus thrombosis and internal carotid artery encasement. Diagnosis by histopathology is the definitive diagnosis, then fungal stain and culture and imaging. Biopsy should demonstrate characteristic wide ribbon-like aseptate hyphal elements that branch at right angles. The organisms are often surrounded by extensive necrotic debris. Reasons for increase in mucormycosis in COVID-19 patients. Hyperglycemia due to uncontrolled pre-existing diabetes. Rampant overuse and irrational use of steroids in the management of COVID-19. New onset diabetes due to steroid overuse and severe cases of COVID-19. New onset prolonged ICU stay and irrational use of broad-spectrum antibiotics. Pre-existing comorbidities and breakthrough infections in patients on antifungal prophylaxis. Treatment given. Urgent medical management and surgical debridement. The choice of drug to treat mucormycosis, amphotericin B. Azole compounds such as posaconazole and isavuconazole in case of intolerance of the treatment regimen or generalized weakness of the patient. In our study, all presentations were not typical. The major risk factor was diabetes. Mortality was 30%. Less severe symptoms and better prognosis were observed in patients without previous history of COVID-19. A p-value of 0.175 was observed as per chi-square test among COVID and non-COVID, which is not significant, maybe because of the small sample size. Conclusion: rhinocerebral mucormycosis can occur in people with or without previous history of COVID infection. Presentation may not be always typical. Factors required for the success in mucormycosis management: early suspicion leading to timely diagnosis, control of predisposing conditions, mainly diabetes, complete surgical debridement, and appropriate antifungal therapy. Thank you.
Thank you, Dr. Sarada. Excellent presentation, and you shared your experiences of various cases, and really it has made a condition very worse of the patient. A lot of